Welcome to
This meeting is being recorded.
welcome to this fantastic webinar that we're having with our distinguished guest, who will be introduced in a moment. My name is Gustavo Friedrichsen. I'm the CEO of the LA County Medical Association, and I want to welcome all of you to tonight's event. And with that, I want to turn it over to Dr. Omer Deen, who, along with Dr. Hector Flores, have been really spearheading this entire project to increase engagement, awareness, and knowledge around healthcare reform in California from a variety of diversity of perspectives. So Dr. Omer Deen, I turn it over to you.
Thank you, Gustavo. Wanted to thank all of you for joining us tonight for this series. We're very excited to have you with us. Gustavo, wanted to thank you and Lisa for all your hard work in putting this together, and Noemi. Wanted to thank our board members also for joining us for this talk. You know, I was looking at Dr. Shortell's bio, and I was thinking, how can I concisely do an introduction without eating into the time too much? And I realized he's far too accomplished for me to try to make this concise. So I'll do this as quickly as I can, but really, really thrilled to have Dr. Shortell with us. Stephen Shortell is an MD, MPH, and MBA. He's the Blue Cross of California Distinguished Professor of Health Policy and Management Emeritus, Dean Emeritus, and Professor of the Graduate School at the School of Public Health and Haas School of Business at University of California, Berkeley. He served as Dean of the School of Public Health from 2002 to 2013, and he is the founding director of the Center for Healthcare Organizational and Innovational Research and co-director of the Center for Lean Engagement and Research in Healthcare. The author or co-author of over 350 peer-reviewed articles and 10 books, Dr. Shortell and his colleagues have received numerous awards for their research, including the Baxter Allegiance Grand Prize for Innovative Contributions to Health Services Research, the Gold Medal Award from the American College of Healthcare Executives, the Distinguished Scholar Award from Academy Health, and the AHA HRET Trust Visionary Leadership Award, amongst many others. He was recently elected into the Modern Healthcare Hall of Fame. His research examines the formation and performance of integrative delivery systems, the organizational factors associated with quality and outcomes of care, and the factors that influence the adoption of evidence-based processes for treatment or for treating patients with chronic illness. He is currently conducting research on patient engagement, value-based healthcare delivery models, and on lean management applications in healthcare. He is an elected member of the National Academy of Medicine and serves as an advisor to many organizations committed to improving health and healthcare in the United States. And you can see why he is going to be such a great speaker tonight. So with that, I don't want to take up too much time. Dr. Shortell, I'd like to turn it over to you.
Okay, thank you, Dr. Dean and Dr. Flores, for the invitation. I'm delighted to be here and spend the time with you. And I also just want to begin to thank all of you who are online here this evening for the work that you do. I think a lot of humility on my part. You know, I study healthcare and write about it, but you all actually do it. And so if any of the work that I or my colleagues do, and those of us around the country, that maybe helps inform your work from time to time, that is great. But I just want to acknowledge that from the beginning. If we go, Lisa, to the next slide, and I'm going to talk maybe for 35, 40 minutes, and we'll leave plenty of time for questions and discussion. But this is kind of the roadmap we're going to follow along with. The challenge and the opportunity we have, particularly here in California, the essential elements of integrated care delivery models, the role that all the transformation we're trying to do now with these value-based payment models, we'll hit on those, highlighting some of the evidence to date, and then also talking a little bit about health equity and how that might be incorporated under the capitated integrated care model. So we're kind of go over this and use this at least as a rough outline. If we go, Lisa, then to the first slide, which is the challenge and the opportunity, this really is, I think it's one back, Lisa, I think. No, this is good. This is good. these are things you know. I'm just going to underscore them. We know we have the most costly health system in the world. And in fact, healthcare expenditures are still growing percentage-wise higher than our rate of inflation or our GDP, and that's projected even next year as well. We know there's a lot of waste. The key article here is Journal of the American Medical Association. Some of you may have seen it. 2019, Will Schrank, who actually graduated, was out there at UCLA for a while. About 25-30% waste, low value care, rework, medical errors, inefficiencies, etc. We have some of the poorest outcomes among all the OECD countries, but most of all, we have highly variable quality of care. There's 2-3-fold, sometimes more differences across hospitals in maternal and morbidity rates, even trying to control for differences in illness. And we know in particularly our African American and Latino, the figures for them on the health outcomes are even worse. So, this is a huge issue. It's been with us for some time. Some believe we're making incremental progress. Others believe, yeah, but it's not fast enough. And here in California, we've prided ourselves as being innovators, being the first to try things out, and maybe we can move a little faster. I'd be interested in your thoughts on that as we go through this. The next slide, Lisa. These are certain advantages, I think, and opportunities we have here in California. We've had a very innovative health insurance exchange over the last 10 years or so, covered California. It's been an activist exchange. It's, I think, the best in the nation. I think it's done a particularly good job in terms of targeting and getting insured some of the underserved communities and populations we talked about earlier, increasing enrollment in vulnerable communities. More work to be done, to be sure, but this is something we can build on. Most particularly, we have a history of organized medical groups in the state, and the IPAs working under the delegated model. Many of you participating tonight are undoubtedly a part of that. And then, as Dr. Flores knows, and Dr. Deen, and again, many of you may be on the call, we've had the leadership of IHA, the Integrated Healthcare Association. Hector and I have been on that board for some time now. Pay for performance, of course, and I'm going to show some slides on that later on. But it's been a great forum to bring together the payers, the providers, the suppliers. They even let a few of us academics in, I think mostly for entertainment from time to time, and we try to live up to that. But in any event, it's been a key factor in the state and another one of the advantages, I think, and opportunities we can take advantage of. The next slide gets us into the meat of what I want to put out there. And again, you know most of this, but I want to kind of unpack it a bit and elaborate on it a bit. And this is based not off the top of our head or just a list, but probably about 3 decades of research that many people have done in the health services research community. And they're in no particular order, but the importance we've learned of stratifying patients by level of severity, the advances in big data, data science, electronic health records, the functionality of those records, etc., so that we can now begin to stratify patients by level of severity to do a better job of lining them up with the resources that they need to be treated and not to waste the resources we have to provide that care. It's huge. Proactive, coordinated, team-based care. We now know that primary care and specialty care is not individual, it's team-based care that's really important. And I want to put out there the concept of how many medical groups and IPAs are really what I would want to call better care organizations, BCOs. And those BCOs at the center have these coordinated team-based care models. Part of that is the third bullet, where you use specially trained nurse care managers to work with those complex high-need patients, linking them to social determinants of health, community-based organizations, follow up, making sure the referrals were really completed to mental health, et cetera, et cetera. We'll talk about that in a bit as well. The ability and the skills to really engage patients in pre-visit planning and mutual goal setting and shared decision making, all of that accelerated, made more possible by the electronic health record, of course, but functionality issues there. Motivational interviewing being key. About 4 or 5 years ago, my colleague Hector Rodriguez and I at Berkeley, we had a grant from the Patient-Centered Outcomes Research Institute, PCORI, where we worked with your medical groups in Southern California that were part of Healthcare Partners. And I know they were bought out by DaVita, and now they're a part of Optum. But nonetheless, we studied patient engagement, learned a lot from that. And that's made it into the literature, and hopefully they found it useful to them as well in terms of some of the lessons we learned. Wide use of evidence-based guidelines, say no more. Integrated information systems where you can link to your hospitals, you can link, big challenge now, to community-based organizations that may not at all be on the same electronic platform or even have an electronic platform. So this is important. Performance management system where you get feedback, you can compare with each other and learn from that. And then most important is the clinical and managerial leadership that you need in your medical groups and IPs to continuously learn what's working, strong leadership, bringing people along, etc. So these are the essential elements. You probably know about them all. There's a lot of evidence to back these up as well. The next slide reinforces these, I think, in terms of team-based care. So we're just bringing them down to the level of the team, engaging with patients and their families. Not what's the matter with you, right? Going immediately to all the clinical workup and the diagnosis, et cetera, and let's get on with it. But first, trying to really ask the question, not what's the matter with you, but what really matters to you. Tell me what you're trying to achieve today. Tell me about your home situation. Tell me about what's anxious and what's worrying you, et cetera, et cetera. You need resources and capacity, these teams do, to provide care or arrange for all needed care. You can't do it all yourself necessarily, but the ability to arrange for it. To actively coordinate that care across providers and sites and over time, the longitudinality. To assume responsibility for health outcomes and cost of care, that part of it at least that's under your control. Every team are practicing the top of their license, its competencies. And there's issues here, as you know, particularly across some of the states. We're not making full use, perhaps, of the advances that have been made in nursing education and competencies and pharmacy and social work and so on. So we can go back to that if you're interested. Access increasingly to point of care data that's now becoming available on performance with systems and training to continuously improve care. I've learned recently that Epic, and I don't know how many of you are on Epic or your hospitals are, have a database they call Cosmos, and they're rolling out a product called Patients Like Mine, in where clinicians can access the database and get national data on that patient in front of them with that problem. What does the data nationally with thousands of patients, maybe, or at least several hundred, say about the best treatment options for that patient? They're planning to expand this over time. I think they have 150 million something patients in the database currently, and they're going to expand that over time. So that's one example of increasing point of care data on Cosmos and Epic. Receive timely feedback on the quality of care that they are providing. Patients have ready access to their claims, electronic record data portals. I have that now the last 4 or 5 years. It's been just terrific. It's grown in functionality over time. I know I really appreciate it. Can identify the high-risk patients, we said that earlier, and have access to the behavioral and social needs and resources if you don't have them available in your practice itself. So these are some criteria for these better team-based care within better care organizations. The next slide. Here's the evidence, and it's not exhaustive, but again, these are not off the top of our heads, or just, of course, there's studies that show patients receiving care with poor teamwork are almost 5 times more likely to have complications or die from surgery. Teamwork. In the research that I and my colleagues do, some people have developed something called relational coordination. It has 7 items. We used this in the research we did with healthcare partners. And that's the extent to which members of your team, yourself, your medical assistant, if you have social worker, dietitians, nurse practitioners, receptionists, community health workers, etc., are goals really shared and understood? Is everybody on the same page with the treatment plan for the patient in front of you that day? Okay, or do they just show up to work, and they're just part of the process? Mutual respect, trust among you, okay? And then it has to do with communication. And we measure that along 4 dimensions. How accurate is it? How frequent is it? How timely is it? Those aren't necessarily the same thing. And is it really problem focused? So there's measures of these, and this is around what we did our research with healthcare partners as an example. Teams that are more patient-centered and have champions make more in-depth changes to improve chronic illness care. This is based on a study we did with colleagues at RAND 20 years ago with funding from the Robert Wood Johnson Foundation, who at the time were really trying to improve chronic illness care. So this was key. A different RAND study has found that patient-centered medical homes using team-based care had better quality care for patients with diabetes, reductions in hospital admissions and costs than should be in their non-team care-based PCMHs. Another study of primary care practices found that teams provided better care and outcomes than solo providers for patients with diabetes, hyperlipidemia, and hypertension. And most significantly, there's been recent, what we call a meta-analysis of 31 studies of teams, pulling all of this stuff together, found statistically significant. We can argue whether or not they're clinically significant, but a lot of people think they are, but at least statistically significant, medium-sized effects. They weren't always large, but they weren't small, on performance across multiple tasks, including postoperative complications and bloodstream infections, sepsis, etc. So this is just an example of some of the evidence behind some of the things we're talking about tonight. The next slide. This just brings it kind of all together. Some of us like pictures more than words. Some of us are right brain, left brain. So what we're talking about, if we want better care in this country, we should have to start paying for it. Now we pay for sickness, we pay for illness, we pay for fixing people up after the fact. So if we can move to more of these value-based care models, per member, per month capitation, global budgets, risk-based contracts, downside as well as upside, bundled payments, okay, pay for what we want, right? That will incent greater prevention and outreach. If you get your money up front, you might want to spend it on a community health worker to get to some of these people rather than waiting until they come to you or you see them in the emergency room. You have more incentive to keep your people well on your enrollment panels. You have more money up front to innovate in redesigning care. That may be telehealth modifications, that may be hospital at home, which is beginning to track now, right? More incentive for technology-enabled team-based care, et cetera, and more incentive to really spend more time maybe with patients, engaging them and their families. You've earned your revenue up front, et cetera. You have a way to allocate your budget where you think it's going to make more sense, and you can get rewarded for that under various kinds of savings models, depending on payer and a lot of other issues, of course. Intermediate outcomes produces better clinically integrated care, end result, higher clinical quality, patient-reported outcomes and experience, total cost of care. And perhaps we should add to this slide a bullet for greater professional satisfaction, maybe less burnout. should be added here as well. Better professional experience as well. There's some evidence to support all of this. It's not overwhelming. It's not always conclusive, but as we like to say, it's, we think, directionally correct. If we go to the next slide, what we have here, therefore, is the importance of all payers here in California, and what Dr. Flores said earlier, or Dr. Deen may have, of moving payers more towards capitation. So here's an interesting little study I ran across. Medical Group Management Association did a study of nearly 1,000 primary care practices. And I want to make sure I'm communicating this clearly. They did some models in which shifting to team-based care for complex chronically ill patients, but there was kind of low complexity, right? If 63% of the payments were capitated, okay, this was the cutting point, the tipping point, 63%, then in the modeling, almost every one of those practices had a financial gain. In other words, right now, as you probably know, at the level of the percentage of patients or the percent of your revenue that's capitated, it may be 25, 30%. You have a whole variety of contracts, but it averages out to only about 25, 30% of your revenue really comes from capitation. If that were raised to 63% in this model, at least, everybody would be better off financially, but it's below 20% were capitated. Almost all of those practices would lose money, okay? And a lot of it has to do with the underlying differences and how the practices treated chronically ill patients under capitation versus fee for service. When you're capitated, you can reach out, you can do a whole bunch of stuff that reduces the cost of treating these patients. You've earned your capitation up front once they enroll per member per month, and you do well financially. If you're not, you got to rely on that fee for service, grinding stuff away, fixing people up after the fact to make it work. So this is an interesting study, and yet fee for service reimbursement still accounts probably for over 70% of healthcare expenditures in the state. If we go to the next slide. There's increasing evidence that for higher quality and lower costs from risk-adjusted per member prepaid payment. One is the ACO experience over the years now. The savings with a net of the studies, 1-2%. Doesn't sound like a lot percentage-wise. It adds up to quite a bit of money when you multiply that out with better quality, if anything. New models, as you may know, CMS is trotting out. REACH is one model in which they're working on incorporating social determinants of health and equity considerations into the payment models. I'll say more about that later on. The Medicare Advantage experience, very controversial in some quarters, but there's beginning to be overwhelming evidence that their quality metrics are better than traditional Medicare, lower costs. They're certainly growing in popularity. Over 40% of those eligible for Medicare now are choosing Medicare Advantage plans over traditional Medicare. There's been a lot of criticism of Medicare Advantage around coding issues, et cetera, but they're beginning to be addressed. MedPAC and others in CMS are beginning to address those. But this is a prepaid model, not the traditional Medicare. And this has tremendous, we think, evidence of better quality and lower costs. The California IHA experience with pay for performance, where the full risk, those of you that have accepted full risk, both the professional fee part, the hospital part, have higher quality on the clinical measures, many of them HEDIS kinds of measures, and lower cost than the professional risk. And professional risk in turn tend to have better quality and lower cost than fee for service. And the Medicaid managed care is beginning to take hold. Of course, we have the Cal-AIM here in California growing now or beginning to evolve. Oregon showing some data around their coordinated care organizations. The next slide shows the IHA pay for performance. Some of you have seen this. Those of us on the IHA board have seen this. And just to interpret this slide, what you see in purple, if it's showing up, is that practices that are under no risk, pretty much full fee for service. As you see there, on this y-axis going up is the clinical quality composite score. It's low, right? As we go to the right, professional risk and then full risk, you see that purple bar going up. So clinical quality increases with professional risk, and then full risk goes up. The gray going down are your costs. Most costly, and that's on the axis over here to the right, most costly, as you see the gray, are the fee for service goes down with professional risk, goes down even more for full risk. Now, these were 2019 data, and the 2020 data are now out. I talked with them just last week, and the graphs show similar. The graphs show similar. Not so much different between professional risk, I think, and full risk now on cost. There is on quality. But certainly with no risk, these differences still show up. So that's based on the 200 medical groups in the state participating in IHA's ongoing pay for performance models. If we go to the next slide, I'm going to add some data that no one has seen. Maybe I've shown them in a few presentations to America's Physician Group and maybe others, but they're not in the published literature. And they're based on data sources that we have available at Berkeley through our research center and collaborations with the Dartmouth Institute and 5 years of a Center of Excellence grant we've had from the Agency for Health Research and Quality. And I managed to find, well, not by name, but get data on 219 practices in California and compare them to the rest of the country who responded to this national survey that we did with our colleagues at the Dartmouth Institute. And we had some involvement of the folks at Harvard as well. And what this shows is we're doing pretty good here in California. A long ways to go. Notice these percents here, right? We had scales from 0 to 100. Higher is better. Care of complex, high-need patients. 46% of California practices versus only 39% for the rest of the country. Scored higher on the care of complex high-need patients. These values are all statistically significant. We had another scale of shared decision-making. Of California practices, 49 versus 42. The functionality of using EHRs for decision support, calling people in from the registry, et cetera, who need immunizations or preventive visits, what have you, 63 versus 55. Whopping difference in use of evidence-based guidelines, whopping difference in use of registries. So this experience of pay for performance, or this experience, greater experience of having these integrated medical groups shows up. But look at those percent, it's still less than 50% in many cases, except for the evidence-based guidelines and the use of registries. So why aren't we doing more in California? It might be a question we can put, but we are doing better than the rest of the country. The next slide continues some of the data we had available from our national survey. So we looked at the participation of all practices nationally in payment delivery system reforms. We listed out 9 of them, from, partial risk, full risk, bundled payment, I mean, you name it, full capitation, ACOs, et cetera, et cetera. And then we had scales. We measured all of these measures you see on the left-hand side. And what this shows is modest, small to modest correlations, but in the direction you would expect, namely, the more payment delivery system reforms the practices participated in, the higher they scored on these scales across the board. Care transitions at the bottom, you can go up, you can read them as well as I can. Screening for social needs. The only one it didn't was screenings for clinical conditions, and you can argue that everybody does that now pretty much. But in any event, these are in the direction one might hope for. Again, building a national evidence base for this. The next slide will show you, we measured the percentage of the patients you see that are covered by ACO contracts. It's not enough. It's not penetrating to the tipping point yet. But look at the difference between those of you who said, I say those of you who participated in our national survey, Some of you undoubtedly did, but these are national data, a couple thousand practices, over 2,000 practices across the United States. Most, you can see the differences there. If they answered most or all, okay, of our patients are covered by ACO contracts, it was like 46.46 with the score 0 to 100 on care of complex high need versus 0.40 if they reported no, none of them are, or yes, we have some, but not most or all. And you can go down the rest here, almost all statistically significant. Screening for social needs, use of guidelines, decision support, engagement strategies, okay, quality information, care transitions. No difference again on clinical conditions, everybody's doing that. And also a lot of people are beginning to participate in the quality focused payment programs. But again, the greater the extent to which they have patients covered by these ACO contracts, then the higher they score on these evidence-informed, if not totally evidence-based measures of processes to promote high quality care. Next slide. We then went to look at your percent of revenue, and we divided it into bottom third, middle third, and top third, percent of revenue that had cost of care incentives. In other words, if you were able to hold down the cost of care or you're under cost savings, then how did you score on these measures? There's not a significant difference on the first three, but on the next six, there is. Screening for social needs, 0.38 versus 0.32 for the bottom three. Evidence-based guidelines, not much difference between the middle third and top third, but between them and that bottom third. Again, the same for ERR-based decision support, not much difference between middle and top, but between the lower third. And that kind of holds, as you notice, for the others as well. So the real cutting point here are between those practices in the middle and top third. You could lump them together versus those in the bottom third. But there are a few differences even between the top third and middle third. Again, some more evidence. And then recently, my colleague, Hector Rodriguez, and I, working with people at AMGA, the American Medical Group Association, were able to link the national survey data with the members of the American Medical Group Association. And we're able to use that to divide the practices of AMGA into those that we call very robust care capabilities, a middle group, and then a group with very limited capabilities. We then were able to link that with Medicare data on spending and related kinds of measures. And this article just came out in Health Affairs. It's a brief abstract here, but I'm going to show you the results. If we look at the next slide, Lisa, these were not quite the results yet, but these were the practice capabilities we looked at. Care of complex patients, the use of the guidelines, the use of decision support registries. We had measures of what we call a learning-oriented team culture, how they responded to, we're a practice that likes to try new things, we innovate, etc. The capacity for innovation, depression care management, patient engagement that I mentioned earlier, patient responsiveness, which comes from an original measure of Baldrige, and then also their use of patient-reported outcomes. So these are the capabilities, and we were able to do cluster analysis, and they clustered into three categories of
Did we lose Dr. Shortell?
Yeah, you just did.
I think so, yeah.
We'll see if he can get back on. Thank you, those who have submitted questions. When he's done, I'm going to start off with the cost of making this transformation. The upfront costs, particularly the IT. Dr. Horowitz submitted a great question that the HITECH Act didn't really reach all the smaller practices in particular, especially those in underserved areas. And those are the ones that have a bigger hill to climb to make this type of transformation. So we'll start off with that. And then
Dr. Flores, can I see back on if he's, what about one of the problems that we're seeing now, a lot of people are dropping out of these insurance groups practices because they're not getting paid adequately enough to continue on in these PPOs. And so I'm just, I mean, that's like an issue. I'm hearing it from physicians that are out there practicing, they can no longer accept the insurance. And then I'm hearing it from patients that are disturbed that their doctors are no longer accepting their insurance. So they have to find other caregivers.
Yeah, you're absolutely right. It really speaks to another question that several folks submitted, which is the health insurance industry is trying to cater on the commercial side, cater to employers. And employers are looking for lower premiums. So they sort of say, I'm going to give a defined contribution to premium every year. And if there are any increases, the employee has to bear that. And then they get benefit design that includes deductibles and copays that are really prohibitive. And that's where it starts to get into a problem, because now the health plan has a fee schedule that underpays doctors, and patients have way too much money out of pocket, and it starts to disrupt care. It's a big issue, and there's a lot of hope that maybe the innovation in Covered California, but also a public option plan, which is another question that came in the chat. So we'll pose that to Dr. Shortell. Thanks for highlighting that.
Can people hear me again now?
Yes, Steve.
Yes, you're back.
Yes, sorry about that. I don't know what happened, but in any event, here we are. Okay. So in any event, if we advance to the next slide, thanks, Hector, for substituting there. But I think we haven't lost too much time. What we found with this study is those robust practices had $615 less spending, risk adjusted, than mixed capability, and $500 per beneficiary less spending than those with limited. There are no differences in our quality of care measures. And most of it, by the way, very interesting, was accounted for by lower spending for evaluation and management services and outpatient spending. So if we go to the next slide, Lisa, and I'll make sure we do have enough time for the questions. I do want to bring in a little discussion of health equity. First of all, Paula Braverman, a colleague at UCSF, I think we can all agree everyone has a fair and just chance to be as healthy as possible. And we all know there's just so much that healthcare can do in that regard, and physician practices to remove obstacles around poverty, discrimination, barriers to safe environments, affordable housing, education. Yes, healthcare is a part of it all, but healthcare should be provided according to need and not based on personal characteristics or economic and social position. There was a little piece my colleague did in Milbank Quarterly, if you're interested in looking into that further. If we go to the next slide. So there have been some state initiatives here in California. Some of you may have been a part of these. During the COVID, we used the California Healthy Places Index based on 25 community attributes to try to get targeted outreach to COVID and the vaccinations, et cetera, into communities that scored high on this index. And we've learned some things from that. There's a bill, I'm not sure whether it's passed or where it stands currently, some of you might, to propose a health equity fund. It's AB 2038. It would allocate $60 million per year over the next 3 years, targeted to communities most affected by the pandemic. And perhaps some of your practices that are in those communities would have access to these funds to make some changes you want to do, or to incorporate social determinants, measures, and outreach into the work that you're doing. So that's something to tee up. And then Cal-AIM, of course, has their whole person care initiative, Cal-AIM Medi-Cal waivers, to get at incorporating social determinants as well. So I do want to call those out. The next slide, Lisa. One of the things to use, and people are beginning to talk about to make the adjustment, is the area deprivation index. And it's based on neighborhood characteristics at the census block level, which is as great advantage. Developed by people mostly at the University of Wisconsin Population Health Lab there. It's based on income, quality of housing, food insecurity, etc. Overlaps with the Community Healthy Neighborhood Index I mentioned earlier. And then IHA is also working with RAN on an algorithm based on zip codes that doesn't rely so much on the area deprivation index. So there's some work going on there as well that might be a sort of a shortcut, as it were. But work is going on to try to incorporate some of these kinds of adjustments. Obviously, capitation, if you're seeing or enrolling patients that are sicker or have greater complications or greater challenges in terms of maintaining their health because of where they live, you ought to be paid more. That capitation rate ought to be higher to pay you for what you're going to need to do to keep those people well, prevent them from getting ill. And that's the whole idea behind trying to incorporate social determinants of health into payment adjustments. Not only here in California, but CMS experimenting nationally with their REACH initiative is one example of that. Okay, next slide. So the next two slides are really 2 or 3 winding up now. I'll leave time for your questions. This goes back to high level that may or may not help some of you who are clinical leaders as you strategize and deal with the complex world. And this is the major 4 components, the way of thinking about what needs to be aligned to achieve better clinically integrated care. It has to be a priority, true north priority of the organization. You've bought into the Kool-Aid, okay, because there's evidence behind the Kool-Aid. Strategic dimension, structural, you have to have that in alignment at all levels, organization-wide, departments, divisions, increase, not inclined, increase patient-caregiver interaction. Do you have the structural forms in place for learning? Cultural, beliefs, values, norms of continuous improvement, whatever your improvement model is. It may be lean, it may be something else, it may be robust performance improvement, whatever it is. But you can't ignore the technical, the skills that people need to have, the training, the access to actionable information. And here's what we have found on the next slide. And this is obviously oversimplified and a bit glib and a bit stylized. But imagine these zeros and ones. In between is probability from 0% to 1 representing 100%. So what happens when just 1 is missing? If you're missing this being a strategic priority for your medical practice, you may have the other 3 in place. You've got structures, people are bought into the culture, people are well trained, but if it's not a priority, you're going to get very little impact on anything that really matters. That's the 0. In the next row, the structure is missing. The others are there in varying degrees. We show them stylized, they're fully there. You won't capture the learning. It'll be sub-optimized. Going back to healthcare partners, I don't know, they have 50 locations in Southern California, 21 of them doing well, 10 not so well, 15 maybe miserable. The inability to capture the learning and spread it throughout the organization. By the way, I was just using them as an example. It wasn't true, but you get the idea, right? If the structures and forms aren't there to spread the learnings. In the third row, the culture is missing. You'll get small temporary effects. Nothing lasts. People really aren't bought into this stuff. There may be structures to learn. You're saying it's a priority. They're skilled, but they really don't get it. It's not in the DNA. Then the next row, the technical is missing. A lot of frustrations and false starts. We've seen this. A lot of underperformance. So your physicians, your nurses, they get it. The structures are, but the training is missing, okay? And the bottom row shows what's really needing to improve clinically integrated better care. It's a huge task. And the next slide is pretty much the last slide. David Blumenthal, some of you know, is president of the Commonwealth Fund out of New York, and he said it very well, I think. And I don't need to tell you, this is very difficult work. Creating integrated health systems that function seamlessly to organize care for patients is devilishly hard. requires strong, consistent, talented, and courageous leadership to overcome the huge barriers to making integrated systems work at the front lines where it matters, where the patients are, at the front lines where it matters. So I really want to wind up with that slide, go to the last slide, which is simply to thank you. And if you want more information, it's there. So I think Dr. Deen, Dr. Flores, I'll wind up with that and we can go to the questions and discussion.
Well, thank you so much, Dr. Shortell. I know that everyone's collectively applauding this great presentation. You know, and let me just start off with some questions that came in through the chat and also were submitted before, and combining them a little bit. Transformation is significant and it's important, as you just described in those last few slides. But the barrier to entry, especially for smaller practices, and particularly those in underserved areas where their payer mix is prohibitive, the barrier to entry is the cost of that transformation. Building teams, new policies and procedures for the role that they will be playing, technology upgrades. Who is paying for that, or who should these physicians turn to?
Yeah, no, it's a really good question, Hector. And absolutely, there needs to be investment for the smaller practices. And some things that are, and some of you may be participating, the California Quality Collaborative has a transformation performance grant, the TPI grant of some sort, and they're doing some work on that. It's funded by some of the foundations, and I think they may have some money from CMS, but I'm not sure. I and others, every 2 weeks I meet with an informal policy group via Zoom, and we've had several meetings now with the people at CMS and CMI, and we make your point. We say, in effect, there needs to be more technical assistance and funds to make these kinds of investments if there's a willingness there to do it. IPAs, you know, some of them can help out with the smaller practices as well by providing centralized infrastructure support. Some of the health systems can make these investments. That's where some of the deep pockets are, as we know, and they can invest in and provide some of this also. But that is something that needs to occur, and you may know more than I do, but I think it's been fairly highly variable, and maybe people haven't appreciated the extent to which it needs to be put on steroids if we really want to get to the tipping point.
And I think, you know, it's kind of all over the place. Yes, in some areas, no in others. And maybe this is something you and I can bring to IHA as part of the health equity initiative, that the health plans who are there, the 14 largest health plans and Medicare and Medicaid, should collectively say, we're going to invest across the state, maybe partner with the governor to get some of the surplus that we're dealing with right now to make that transformation possible. Because I think a lot of folks are going to be left behind.
Okay, that's it. Yeah, happy to explore that, Hector, with you further. Yeah,
let's plan on that. Yeah, as a follow-up on team-based care, you know, everyone working at the top of their license or even their training, right? We have frontline personnel that are lay personnel, have a certain amount of training that also needs to be optimized. One recent phenomena here in California is AB 890, you know, Jim Wood's bill to give nurse practitioners independent practice authority. And one of the things that was missing in that debate, I was part of the California Future Health Workforce Commission. And although we value what nurse practitioners or physician associates, you know, it used to be called physician assistants, bring to the table, their training is very different. And there's concerns, and also expressed in the chat, that this movement, may displace physicians with a misunderstanding that a nurse practitioner can do what a physician does. Maybe over time, as lifelong learners, things change, but the training is very different. And number two, that may actually lead to unanticipated outcomes. And I don't know if you've had a chance to look at that, the impact of that in other states. Obviously, this is a new thing in California. The regulations are being written as we speak, but I don't know if you've had that experience.
Yeah, I have not, Hector. It's an area that I don't have a lot of expertise in, or I have not, you know, studied directly. I know it's an issue, and I think what's important here is to have the forums, whether or not it's the Workforce Commission that you were a part of or something else ongoing, to explore where it makes sense and where it's safe for patients and what really makes sense. And the frame I would put on it, it is not the frame of let's protect our profession, whether it be nursing, social work, primary care, or whatever. But what is it that the patients really need in 2022 and going forward? What are the health issues? And then back into, okay, what are the kinds of competencies that people need to address those issues? And then back into, okay, the training, what training is going on in whatever, nurse practitioner school, primary care now, you name it, back into it and try to see what kinds of innovations can occur or experiments where it's a glide path to make sure patients are protected and safe, but also it makes sense that the explosion of scientific knowledge, et cetera, we probably need to redefine professional roles. We need to provide healthcare in lower cost settings using lower cost personnel, practicing according to clinical standards, right, et cetera, and learning how to redesign care. So again, it's not an area I looked in depth, but kind of that's the frame I would put on how to think about those issues.
Great, thank you. That's very thoughtful. Following up on the integrated systems, a question that was submitted earlier is how do integrated systems provide solutions for disparities in healthcare, especially for rural and socially economically disadvantaged communities, and for social determinants of health and health equity? Could you elaborate a little bit more on that, how these integrated systems might address that, whereas it hasn't been addressed in the past?
Yeah, no, it's a great question. I think a lot more work needs to be done there. So a couple of thoughts and a couple of examples. One is Intermountain out in Salt Lake City, but a lot of their care is rural. Geisinger in Pennsylvania is another one. The point I'm making is these are health systems working with their medical groups. Some are IPA models, some are salaried medical group models in which they have resources, okay, to redeploy, to incorporate social determinants and to build partnerships with rural America. Geisinger is doing that, Intermountain's doing that. Virginia Mason in Seattle has reached out over the years to, I guess, be east of the Cascades, is doing that with outreach. They partner with the University of Washington, the WWAMI program, Alaska, Montana, Idaho, as well. It's called the WWAMI program, the 4 states there. And I would add to that now the new technologies we have available with the electronic health records, et cetera, and taking advantage of some of the administration work to get broadband out to the rural areas is really important. And so we need to, kind of jump on some of those developments to do a better job with people living in the rural parts. And some of these health systems, these urban health systems, often need to partner more as well. One of the things I've proposed, and it may not be implementable, is as a condition for some of the shared savings and other kinds of things, if you're an urban health system, for example, you would be required by CMS and the health plans, the commercial plans could build this in as well, to build partnerships with rural America or to cover rural America or to get some of the innovations out there. So to bring it home to our state, right? Sutter up here in the north has a lot of rural providers, right? And so they, for example, could be required to say, no, you're not, there'd be various carrots and sticks to nudge Sutter to build more, better healthcare in rural California, for example. So I think that's an issue right in front of us.
That's great. Thank you for sharing that. And following up on sort of the movement towards value-based performance, part of that includes reducing costs. And a major target are hospitals, right? We've seen over the last 10 years, particularly with ACOs and the capitated models in California, that we're moving stuff out of the hospital back into the community or even back into the home. What can hospitals do so they don't become victims of this trend?
Yeah, well, a couple of thoughts. One is if you're part of a capitated, fully capitated model with your medical groups that admit patients to your hospital, you can go that route. The problem now is they have so many different payers that aren't all there, et cetera, and traditional Medicare, if not Medicare Advantage. So it's the proverbial for the hospital executive, one foot on the dock and one foot still in the water, so to speak. Why should I change over? But if you can get towards that tipping point, then you can make it financially from the revenue you're earning up front through your prepaid per member per month payments that cover inpatient care, primary care, etc. And it's up to you and your integrated health system, particularly if you own enough medical groups, and I know there's pros and cons to that, salaried them. This is the full Kaiser model. I'm not saying everybody has to be Kaiser. You've got that money to move around. And so if your predictive models and analytics are saying we're going to have X predicted percent admissions, we need that many beds, and we want that to be a little bit of a revenue center because we need to expand the ICU next year. So let's load it up there. A little less for our primary care practices this year. You have choice to do that. On the other hand, you would have the opposite choice to say we've earned our money up front through our arrangement with all these health plans, or if you're Kaiser, it's an exclusive one plan, right? Mm-hmm. And we're the cost center. The hospital's now the cost center. The revenue is earned by the system. We need to be an efficient cost center, but we no longer need to worry about getting revenue, okay? That's being earned up front through our work with the other parts of our system, okay? So hospitals, it's going to be highly variable across the country. Some of them need to reconcile that they're going to be cost centers, and that's okay because the revenue to pay the nurses more next year with the union, or to upgrade an inpatient part of the facility, or to incorporate a new piece of technology, does not any longer have to come from a repeat DRG or a repeat readmission or any admissions at all, because the savings or the profit or the earned surplus, right, has been earned up front, and it can be redeployed by the hospital and health system leadership towards those increased salaries for our nurses. But that's going to be highly variable, and it might be that you need to still be a revenue center as the hospital component of the system. But we're not there now when hospitals aren't yet, most of them at least, not in that position.
Great observation, and I think it's a good call to action for hospitals to rethink how they do things, for the future.
Yep, it certainly is, and it'll be dragging the AHA and the CHA along.
Yeah, I remember one of your colleagues at an ACO Congress a few years back, Jamie Robinson, was giving a talk, and there were a room full of hospital folks, right? And he said, if all of you ran your hospitals the way Kaiser does, half of you would close. Of course, there's this collective gasp, right? And obviously he was being provocative, but there was a lot of truth in what he said. There was another question here regarding, hospitals sort of feeling like victims in this. And, how do we move away from the dichotomy of there's going to be winners and there's going to be losers? How do we move to a win-win all around? You touched on it a little bit, but clearly there may be some hospital closures as well as physicians giving up their autonomy and joining larger groups. What's your sense of where that nice sort of happy medium would be?
Yeah, it's the balance we're striving for. And I'd like to think, and maybe I'm overly optimistic, that some of what we've talked about here is about raising the whole distribution to the right, as it were, or lifting all boats in the harbor, so to speak, by making some of these changes in national and local health policy. But to your point, Hector, there's always a distribution, and some are going to be at the far positive end, doing really well, many right there in the middle. There's always a tail, right? Now the tail may be a higher performing tail than we currently have. That's the hope, but there's still going to be a tail. There'll be relative, if you will, some organizations, practices will do relatively well, some won't do as well. Those that don't do as well need to plan now for how they can be part of the distribution, where they'll be part of doing well, joining a system, no longer remaining independent. For example, pros and cons. Same thing with practices, pros and cons. Right now, I think you have a choice, but later on, maybe not. And those who choose not, then they will go under, as it were. I mean, we had some of this in the 1990s in California, you may recall, with the initial managed care stuff going on. Some of the practices couldn't make it, and they didn't have the Department of Managed Healthcare came out of that. So there will be, I think, some losers, but I don't think it needs to be. If, to your earlier point, if we really want to transform care in America, we have to recognize that making some investment among those now at the tail end who are really motivated, though. They get it. They just don't have the resources of some of the others. So if we make that investment, and after making that investment, there are still some at the low end, there may be some losers. But what we need to guard against are that they are not disproportionately in our marginalized communities, in rural America, where they worry about the rural hospital closures. Not all of those may be bad, by the way. There's other ways of getting care out there. So that's, I think, what we need to worry about is it going to contribute to growing inequality that we have across, of course, our country, a huge problem, but are we going to exacerbate that in healthcare by some of these things we're talking about? That's, I think, what we have to really guard against.
Absolutely. Thank you for sharing that. Before I hand it over to Dr. Deen to close our program, I just want to highlight two things. One, Dr. Kim Yu gave us some really good resources in the chat. And Dr. Roberta Doucette has had her hand up, and I'll give her the opportunity to ask her question before we close. So Dr. Doucette.
Hello, thank you. Thank you for letting me ask my question. Thank you for the presentation. That was excellent. And I think there was great points. But one of the things I wanted to say was what I'm hearing from everyone, that there's an issue with the insurance companies with paying out with these PEOs, that the physicians are dropping the insurance because they can't afford to run their clinics or practices with the reimbursement that they're getting from these insurance PPOs. And then on the other side of the coin is patients are complaining. I'm hearing about them complaining that their doctors no longer accepting the insurance that they signed up for. So this is like, I'm hearing this on a regular basis. And I think this is an issue that needs to be addressed as well. And I think you had some awesome ideas and great ideas. I'm just putting out there what is a burning issue right now and leading to crisis situation.
Yeah, Roberta, just a quick comment. Of course, Medi-Cal is an issue in terms of payment and so forth, but also the fact that IHA is a forum, as Hector and I know, in which the concern you've raised can be debated, discussed, and so on. And yeah, to be continued for sure, And, but by the way, Hector wanted me to comment, there was an interesting question on the book on donut economics that somebody had sent in advance. I haven't read the book, but I know a little bit about her, the economist Raworth, I guess it is. Basically, if any of you are interested in that issue, because it cuts across healthcare and a lot of things, it's about how do we get balance around growth? It's not just GDP, but it's about balance, about how do we create an economic system within capitalism that makes it where everybody can prosper. So it's really trying to get an inequality. And she raises, as I heard or others talk about this book, in particular, the environmental issues that are going to really affect so many of us, but particularly those in poorer communities. So somebody wrote in that question about donut economics, 2017 book, if any of you are interested in it.
Thanks so much. Well, I know collectively we're all thank you, Dr. Shortell, for a great presentation, a lot of food for thought. And I want to hand it over to Dr. Deen to thank you again and to close our programs. Dr. Deen.
Yeah, thank you, everybody, for joining us. We really appreciate the participation. Some great questions. Dr. Shortell, as always, thank you so much for giving us this presentation and your thoughtful insights on the topic. With that, we're a little bit past the hour, so we'll let everybody go. Have a great evening, and we'll look forward to seeing you again at our next session. Thank you.
Thank you again. Appreciate it very much.
Bye.
I saw one thing in the chat, Medicare for all, maybe Medicare Advantage for all.
There you go. Absolutely.
One last salvo.
There you go. Great comment. Thank you very much. Take care.